I learned that healthcare in the United States is very much practiced through a lens of the historical and cultural forces that shaped our nation and continue to shape our society today. There's this understanding around a rugged individualism that is what makes us most advantageous, most healthy, most prosperous, and that fundamentally is harming those communities that have been historically excluded, Black or African American, Latino or Hispanic, Native or Indigenous, those who are in isolated rural pockets. I say it's fundamentally harming those communities because we're lacking an understanding of the role of collectivism.
Welcome to Pod Talks. Pod Talks is a project of protecting our democracy, where we bring together the best minds in New Jersey and beyond to talk about some of the biggest challenges facing our democracy, our institutions, and our personal freedoms. I'm Sean Spiller, Chair of Protecting Our Democracy. And today I'm honored to have an incredible guest with us who I'm also honored to have as a friend, Dr. Chris Pernell. Dr. Chris, as most of us know her by. Before we begin the discussion, let me tell you just a little bit about the impressive career that Dr. Chris has had. Dr. Chris is a fellow Regent at Large for the American College of Preventive Medicine and has an appointment as a clinical assistant professor at Rutgers, New Jersey Medical School. She previously worked at University Hospital Newark as the first Chief Strategic Integration and Health Equity Officer, where among other many leadership responsibilities, she launched the Health Equity Strategy to integrate diversity, equity, inclusion, and anti-racism initiatives across all hospital operations. Dr. Chris previously led the 1199 SEIU League Labor Management Initiative Workplace and Community Health Program, where she worked to ensure health access and equity to the members of the largest healthcare unit. Dr. Chris graduated cum laude from Princeton University and then attended Duke University School of Medicine. Her degrees include a Master of Public Health from the Columbia Mailman School of Public Health, and she completed her General Preventive Medicine residency at the Johns Hopkins Bloomberg School of Public Health. Many of you will recognize Dr. Chris in her public role as a leading expert speaking on health justice, community-based advocacy, and population-wide health promotion and disease prevention. Dr. Pernell is a frequent contributor across television, radio, and print media, leveraging her lived experiences and expertise as a public health physician and as a health equity champion. She regularly speaks at professional symposia, social forums, and advises community, state, regional, and national health leaders on health equity, racial justice, population health, community well-being, and faith-based initiatives. Dr. Chris has received numerous awards and has been recognized in 2020 as New Jersey Biz wisely recognized her as the public health hero. Now, there's a lot more that I could say about Dr. Chris's impressive career. I know there was a lot there, Dr. Chris. Impressive, even as I say it and I read it over and over, like, yeah, that's impressive. But now let's instead turn to have a great conversation with Dr. Pernell. And first, let me just say thank you for joining me today. I'm thrilled to have it on today. And I also want to just take a personal moment and say thank you also in the heart of the pandemic. You offered so much in terms of a few things we were able to put out, trying to really impact and help during that crisis. I just want to say thank you for that also. I appreciate it.
Thank you. It's my pleasure. And I'm looking forward to have a really exciting conversation over a topic I think is just so necessary and important at this time.
Thank you again. And let's start right there, right? I think,
Sure.
You're an expert in this area, certainly, as everybody I know just heard. So from that vantage point, what are you seeing right now? I mean, I'm cautious in using the term post-pandemic, but let's talk about it in a sense of where we are in the pandemic, hopefully, moving to the other side of that at least. We all saw the challenges there, right? We know the disproportionate impact that it had on communities of color. We know the hesitancy that first existed with vaccines and other pieces, understandably, in the historical context. But then also, underlying conditions, other challenges, when you've got individuals who don't have the same quality health care as others, we saw that disproportionate impact. So I guess overall, it's, where are we today? Do you see that we've taken some steps? Where do we stand?
First, I want us to start from a place of gratitude that we're not at peak crisis mode, right? So I think that's something to be celebrated and something to be applauded, because we really went through an unprecedented public health crisis that impacted every facet of our lives. And that just didn't rock our nation. It didn't just disproportionately rock Black and brown communities in our nation, in our state, in our cities, but it rocked the globe, right? So we're out of that peak pandemic phase and the public health emergency has ended. But as I explain it to people, COVID is still around. And because COVID is still around, COVID is seeking to gain advantage, and those who are most susceptible or most vulnerable are those who unfortunately live at the lower socioeconomic ends of economic growth and development, because they have less access not only to quality health care, but less resources. It's the geographic distribution of resources that allows certain communities to be disenfranchised, historically excluded, systemically oppressed, and discriminated against. So we have our older populations, we have still pockets in our Black and Brown communities, and we have those who have chronic health conditions who remain at risk with COVID still circulating and a part of our everyday lives. But we are not where we were before. We have so many tools in that public health toolkit. Like, I reference this public health toolkit whenever I speak about it, and I literally want people to see a toolkit, to stop and imagine a toolkit. And we have tools, right? We have vaccines. We have our vaccines that necessarily are better than the first generation of those monovalent mRNA vaccines that became available. But we know not enough people are fully vaccinated with this updated bivalent booster. I think at last check, we were only, somewhere in the 20% range of those who had been fully vaccinated with the bivalent booster. That's higher if you look at different age pockets or if you look at different groups. But that's what that updated vaccine. And so we got progress to make on that front. More importantly, are our public health infrastructures as sturdy as they should be? I don't think so. I think our local public health entities are still overburdened and under-resourced. There are still funding constraints, and those funding constraints come from the federal through the state and then down to the local levels, especially in communities where there has been history of discrimination and bias. And what does that mean? Do we have testing that's readily available? We got to a point in the pandemic that testing, was at a critical saturation point. But now that the public health emergency is over, now that private and government insurance will not be mandated to cover a certain amount of tests within a certain amount of time, I'm most concerned for those who are uninsured and underinsured, because when those resources, those government made available resources are exhausted, we really got to get into the thick of it in a crunch again. And so what I want people to understand is that health equity cannot be an afterthought. Health equity cannot be something that we think about once we see how severe or how catastrophic an issue is that we're facing. But health equity must be at the core and the center of every strategy in American life. And unfortunately, I don't think we're there yet. I think we're better than what we were before, but we're not there yet.
So when you talk about the disparity that exists, and I think there's so many directions we could take that, right? When you talk about socioeconomic and other spaces, is the answer where you just ended, which is around that funding? Or I guess, and obviously I'm talking to a doctor, so I imagine this is where you're going, but is the answer around, going at funding for healthcare? Is that the space you see as us needing to, focus most, I guess, in relation to a pandemic, of course, but in relation to trying to close some of those gaps around health equity? Is it funding that moves from all those levels that you noted?
I take a deep breath, right? Because as a physician, I think everyone expects me to say, yes, fund healthcare, and that is necessary. But we need to back it up. We need to think more broadly and to go more upstream, if you will, as we say in public health and preventive medicine. We know that healthcare is probably, let's say, responsible for about 15 to 20% of your health outcomes, rather where you live, right? Whether or not you live in quality housing, whether or not you breathe clean air, whether or not you have access to affordable and nutritious food, whether or not you live in a community that is safe and you can walk streets, whether or not you have access to certain types of mental and behavioral health care, those things, whether or not you earn a living wage, those things comprise the bulk of what drives your health outcomes. And unfortunately, because we live in a caste system, right, where there's different value, and it's hard for people to hear this in the United States of America, but we saw this in the pandemic. Historically, where different value has been placed on different lives in different communities, you have different distribution of resources. That is a fact in the United States. I can quote some stats for you. A study just came out that said that approximately half of Black communities that are predominantly Black, have a dearth of cardiologists. Heart disease is the number one killer, right? Why do they have a dearth of cardiologists? Why are cardiologists not training there? If you were to do a cross-reference of the data, you would find that those same communities have deserts around pharmacy. You would find that those communities have deserts around access to food. You would find that those communities are saddled and burdened with economic and environmental injustice issues. So that's what I want people to understand. Having a doctor that understands who you are, that practices socially and culturally fluent care is important. Having access to quality healthcare systems that make appointments available at times that are convenient for you given your life and how it's structured is important. Having a healthcare system that understands how bias, implicit, unconscious, and explicit biases and discrimination impact care is important. But fundamentally, what is more important is access to a living wage, clean air, safe environments, quality housing, and quality education. We need all of that.
So let me take my deep breath. How do we get at that, right? As I listen to you, speak to that so eloquently and right on point, I think, my own experiences as a teacher, often we have conversations and the impact that a teacher has, and it's at like similar percentages as what you described that an impact can have there versus all of the other factors, the same factors that you just described. How do we as a society get the focus to be on that, as opposed to a pandemic flares up? Of course, there is a focus and maybe some dollars thrown at something and maybe some steps forward, and good, and we're not discounting that. Or there's something that happens around education and people talk about gaps and wanting to close and there's some dollars and some help. But then, the bigger, broader picture, as you just described it, is left to the side. How do we, tie all of these things together, I guess, if it were, and push to say, as a society, this is what makes us stronger and better if we go at these root causes upstream, as you noted, and kind of address these things. How do we get to those discussions, I guess, and more broadly than just the usual people discussing it?
I think we have to tell a fundamentally different American story. And when I first learned health policy, when I first learned how healthcare is structured as a system, and that's when I got my master's of public health. I didn't learn that when I was learning how to become a doctor. I'll talk about that in a second. But I learned that healthcare in the United States is very much practiced through a lens of the historical and cultural forces that shaped our nation and continue to shape our society today. There's this understanding around a rugged individualism that is what makes us most advantageous, most healthy, most prosperous, and that fundamentally is harming those communities that have been historically excluded, Black or African American, Latino or Hispanic, Native or Indigenous, those who are in isolated rural pockets. I say it's fundamentally harming those communities because we're lacking an understanding of the role of collectivism. And what is collectivism? Collectivism is understanding that the fact that there are 1.6 million excess deaths of Black people in the United States is not just a problem for Black America. It's not just a problem for Black communities. It is a problem for all of us. Because whenever we have segments of our population that have less access to resources to live life in the fullest and most robust means, it means that as a whole, we are not as strong, we're not as healthy, we are not as prosperous, we are not as creative. And we have to tell a different story. We have to tell a story where your neighbor down the street is important to your life. We have to tell a story whereby a person who lives just 3 miles from you should not have a different life expectancy. And that telling of that story has to happen at the kitchen table. It has to happen in the living room. It has to happen in broadcast media. It has to happen in schools. It has to happen in workplaces, because that's what the U.S. Surgeon General really is talking about. He's talking about a lack of social connectedness, and he's talking about isolation, and how actually those things worsened during the pandemic, and how actually those things are just more granular because of systemic forces around oppression. But if we can understand that we're all in this together, and that was the struggle during the pandemic, right? Helping people to understand really the only way to solve ourselves out of this pandemic is together. But if we can understand that fundamentally throughout our lives, and then I'll say this before closing, if we can understand that in healthcare and how we educate and train physicians, that there should not be this hierarchy between the physician and the patient, or this asymmetry where the patient does not have voice or power and the physician is all knowing, or the provider is all knowing. We have to get more at shared decision making. We have to get more at whole person care or person-centric care. So we have a lot of work to do, but if we have those crucial conversations and we start that type of dialogue, we can begin to say, how do policies reflect more of a collective understanding of what's best for us and not necessarily just an individualistic understanding.
Well, certainly I'm optimistic and hopeful, as you said there, that if of all the bad that has come of it, if the pandemic and people realizing that the only way through is working together can be a jumping off point for something more, the piece that you described, but let's hope it at least leads to that. So thank you. Hate to kind of put the cold water on that a little bit right from the start, but moving to another area where, we're seeing so much controversy and so much discussion right now is another attempt to divide, another attempt to kind of limit. And that really is about the Dobbs decision, right? I think when we look at the Supreme Court ruling, right, and we see access to healthcare and women's healthcare specifically front and center, with 20 or so states, limiting abortion to some degree or putting outright bans in. We're seeing the elimination of, medical procedures that have been, used forever, drugs that have been used forever in these procedures, banned, attempts to take it away. I guess, how do you comport that? How do you bring that into your thinking in the conversation of us trying to move forward on some things with in a positive light? What do you see, I guess, as first the impact that's going to be on women's health? I mean, I think looking at it, it would just seem logical that, of course, it's going to lead to less healthy outcomes, right? More challenges.
Definitely.
But I guess is that where you see this leads, and then what more can be done right now?
We are in strange times, and I use that word deliberately, but we're not in surprising times. Because if you look through the lens of history, unfortunately, and I've said this before, we've been on this pendulum where we have these broad swings, and you see growth around this understanding of what rights are, growth in opportunity, or growth in access, but that access hasn't been equally or equitably distributed across all groups, or racism wouldn't be the vile evil that it is, or sexism wouldn't be, or genderism wouldn't be, or ableism wouldn't be, right? Or transphobia or Islamophobia or anti-Semitism wouldn't be the vials that they are. So we have to think about, how do we get off of that pendulum, and how do we break the systems that continue to pit us against one another, where we have a survival of the fittest? Because that's where you see disenfranchisement happening. And that's what's happening around women's healthcare. It's disenfranchisement. Patients are losing the opportunities and the access to make decisions around their bodies. They're not able to exercise autonomy, or that word I said previously, to have shared decision-making with their provider or their physician, because there has been an encroachment of government to say, this medical procedure should not be available to you, or that medical procedure should be available to you, when that is a conversation that should be, protected in the doctor's office, protected inside of a person's home or in their familial network or circle. So the way that I term this for people, because rights have not always been evenly distributed across all communities or groups, is a justice issue. And that conceptualization did not begin with me. If you look through time and you look at how this reproductive justice issue has been come to be known, you got to look at a group of Black women coming out of Chicago in 1994, right? Who say that reproductive justice is the right to have personal bodily autonomy. It is the right to have children when I want. It is the right to not have children when I want. It is the right to parent or to nurture or to cultivate children in safe, equitable and healthy environments. And abortion care is one aspect of that reproductive justice issue. I think if we can take it out of this hyper-partisan conversation, right, this political football back and forth, and put it firmly back where it's a health equity focus, right? A justice issue is a health equity focus, right? Because health equity is always rooted in need, whatever a person needs or a community needs. So we can help people to understand that this is a reproductive justice issue. With all those things that I just said, you want the right. You want the opportunity to say, this is my body, and I would like to be able to make certain choices about it. And then help people understand how they have the ability to do that around other parts of care, because that is what's being cherry picked right now, in particular, to safe reproductive care, safe abortion care. And it really is alarming, because where does that slippery slope end? And I don't know. Like you said, there are about 14 states. I was just reviewing it again today. 14 states that have outright banned abortion. There are about 20 states that have, these gray areas around what services are available to women and when. And it's starting to impact issues outside of deciding whether or not to terminate a pregnancy. There are implications for conversations around those who want to start a family and have infertility, so need fertility treatments and to have access to that. So we have to find a way to depoliticize a medical, a health, and a justice issue. I know that's hard. But again, if we can have conversations about the whole and not pitting one another against each other to say, you shouldn't be able to do this, or I should be able to do this. This is, how do we create a society where resources are equitably distributed so that people can then have access to power to make the most informed choices and decisions? That's the battle that we face.
Well, I certainly hope there's a willingness to listen to the people. I'll say this more so. It reminds me a little bit of the parallel around the conversation with gun safety, right? In that you see overwhelming numbers of the people, agree that we have common ground around gun safety and things we can do. And on this, you're seeing, I think, in state after state, including many of those 20 states that we're all discussing here, that there is a swell of people who are saying, no, we agree with, I think, a lot of the way you just described this, but are the electeds that are there going to listen, is I guess the challenge. And I guess our challenge is to make sure that they do.
And can I say something to that? What I hope we learned from the pandemic, right? And this is where, as a public health and preventive medicine physician, I think I can be differentiated, and those others who are Prevmite docs can be differentiated at times from our peers, is as a part of our training, right? We are trained to be the systems thinkers in healthcare. And we are trained to think about those upstream factors. So we understand that there are political determinants of health and life outcomes. We have to have a more informed dialogue around what that means for everyday people, and what that means for people who unfortunately are at the margins of society. When you restrict access to care, the communities that are harmed the most are the poorer communities. The communities that are harmed the most are the geographically isolated communities, so in rural neighborhoods. The communities that are harmed the most are communities that are saddled with historical exclusions and oppression, so Black or African American, Latino or Hispanic, Native and Indigenous populations. That is true of any outbreak. That is true of any epidemic, any pandemic, or any political football issue where rights are contracted. It always harms those who are most vulnerable. And we have to help people to understand that who is most vulnerable or who is most marginalized sometimes changes, right? Depending on the particular issue. But at some point, we all have skin in this game. And the more we can speak truth to power, those of us in healthcare, those of us, those citizen heroes, right? The more that we can hold our elected officials accountable to say, look, I want to be healthy. I want to live as long as I can. We've lost our life expectancy during this pandemic. In the United States, the average life expectancy is 76. But if you break that down for different races and or ethnicities, that's about 70 for Black or African American. That is an appalling 65 to 66 for Native Americans. If you break it out by race and gender, that is an appalling 66 or 67 for Black men, and about 61, 62 for Native American men. And so I say that to help people to understand is that we in the collective have voice, we have power. And it is my hope that those of us who have certain skills, like physicians, like educators, like those in public safety, can share power with all of us in community so that then we can hold systems accountable.
So maybe let's tie that, the next piece, let's tie that all together, and maybe at the other end of the spectrum, and talk about infant and maternal mortality rates and just some of the things there that I think ties right into exactly what you were just saying, right? We see that, again, when you look at Black maternal and infant mortality rates, they far exceed those of white women. You know the data, better than me, and I'm sure could cite it. But specifically around this area, what's is it more of the same? Exactly the things you've been talking about, repeat, if you will. Is there a different way to try and address it? Is there something we could do in a more acute manner to get to that? I know that there are groups, focusing on it, here in our state and others, specifically trying to do something here. What's at the heart of this, and what can be done?
Yeah. So often we're talking about different demographic categories or features around human beings, right? I am a Black woman. I am a Black woman of a certain age. I'm 47. I live in a certain region, right? Those are demographic features. I identify as a woman, right? I was born and assigned female at birth, and I identify as a woman. But it's not the truth or the reality of who I am. It is the ism, the oppression around my identity. So we tell people it is racism, not race. It is sexism, not sex. It is genderism, not gender, right? And I think it's very important for people to understand that. That is why the numbers around maternal mortality are shameful. They're shameful just across all groups at first in the United States. For us to be as prosperous a nation, right? We are suffering disproportionately in maternal mortality. And then if you tease it out to say who is most vulnerable in that suffering, you look at Black and African American women, and that number is 3 times the rate of white women nationally. But, within states, Georgia was faring the worst at one point, and New Jersey wasn't doing that much better. Right? We were ranked like 47th out of 50 states. And so when we're talking about how do you fix racism, because that's how you're going to fix, how do you fix genderism? How do you fix sexism? How do you fix, concentrated poverty? That's what's going to fix issues like infant and maternal mortality. So we begin to think about, okay, when we were in the pandemic, there were conversations about why we saw the disproportionate outcomes. I'm going to take that conversation and put it right on top of this topic. So you think about access to life opportunities or the exposures that people have on a daily basis. Again, where you live, where you were born, where you work, where you pray, and where you play and age are important because you are exposed to different things. And those exposures then either make it more or less likely that you will have negative health outcomes. So if certain communities are saddled disproportionately with exposures, whether they are environmental, whether they are economic, right, whether they are structural, if they are saddled with those exposures, they have worse outcomes. So if we're going to fix Black maternal mortality, if we're going to fix Black infant mortality in the larger issues of maternal mortality and infant mortality, we got to go upstream again. Living wages, clean air, safe communities, right? Access to physical activity, access to healthy and affordable food, because we know that there is a correlation between those exposures and all health outcomes. Then we can get more specific and granular, and we say, what are the health conditions that these Black women are facing that make them more predisposed to have worse outcomes? That heart disease is a killer for all Americans. That cancer is a killer for all Americans. And right now, COVID has flipped from the number 3rd ranked cause of mortality to the 4th cause of mortality. But what I want people to understand is if we know that those conditions are true, let's go back to that stat that I quoted earlier. Those same communities that have less access to that clean air, to those safe, walkable streets, also have less access to pharmacies, also have less access to cardiologists. So we got to make sure Black women have access to primary care, and that when they have primary care, there are conversations around prevention. Studies show where implicit bias harms patients is one, patients aren't believed. So Black women aren't believed. Their symptoms aren't validated when they present them to a provider. So a provider or a health system has to do things, interventions, tools, strategies to check implicit bias, that's that unconscious bias, right? As well as sharing power with patients. So teaching patients how to advocate for themselves. Then we got to think about what does prevention look like in that community? What are the recommendations? What are the recommendations around screening so that health conditions aren't running rampant? High blood pressure, diabetes, and depression negatively impact health outcomes, in particular in the maternal mortality, right? So I'm talking about, again, access to opportunity that drives life outcomes, as well as access to socially and culturally fluent care. We got to track these numbers. During the pandemic, we would have difficult conversations about who was dying disproportionately, but we didn't have all of the data that we needed to be able to make that case. And then states, the federal government, local municipalities said, okay, I got to track outcomes. We need to do that around maternal mortality. We need to be able to stratify data, and we need to continue to monitor it and make that information available down at the level of practices, at the level of communities, at the level of cities, at the level of states, and nationally, so that, again, a patient, a person can be empowered, a birthing person in particular, to say, hey, these are the issues that my community is facing. These are the issues that this particular health care provider has been good or bad at performing around. And these are the issues of these health systems. So it is a multi-level strategy. And unfortunately, if we're not willing to fund at every level of that strategy, we are going to still see Black women disproportionately die, and they should not.
Well, when you look at all these things that we've been talking about, whether it be topic, systems, broadly talk about a number of different systems here even, what do you see as the impact, or maybe a better way to say it, can we have a healthy overall system, meaning our system of democracy, right? Let's go to that one. Can we have that if we're living in all of these other systems where it is so easy, for people to look and see that this system or that system disproportionately harms me, right? Or holds me back? It is, can we have a healthy, vibrant democracy when we see the challenges? Let's go to your expertise area. When we see the dynamics going on in healthcare, when we see the challenges there, can we have a healthy democracy when we have these challenges?
No. And I say that with you saw I didn't skip a beat, right? No, right? If you look through the lens and the prism of history, our democracy has never been healthy. Idealistically, the idea of our democracy, the idea of what we should be as a nation, has been something to aspire toward and to inspire communities. But we have never equitably shared rights or access to opportunity across all groups, right? I think about, I just met a 100-year-old Black woman, and I think about what she has seen. And I think about it through the lens of my grandmother. I lost my grandmother when she was 97, and what she experienced. She wasn't always able to vote, right? She wasn't always able to move freely around and about in American society. My parents grew up in the Jim Crow South, and because they grew up in a Jim Crow South, they didn't have equitable access to education. They didn't have equitable access to earning a living wage. There was the tyranny of lynching, the fear of segregationist terror and policies, right? And how that impacted their health outcomes. And so we have to have an honest conversation about digging up roots, right? Digging up roots in a society that still values certain lives above other lives. And I'm really tired. I'm tired of having conversations that are not transparent, where we can't talk about issues like white supremacy, about white privilege, or the privilege that men have, or the privilege that Christians have, or the privilege that those who identify as heterosexual have, or the privilege that those who are of a gender and are not non-binary have. We have to be able to talk about that two-sided coin, where one group has privilege, advantage, preferentially, not because of their own ability, but because of something historically, and that another group is oppressed or has less privilege. In our democracy, we have to fundamentally rewire that understanding so that everyone can have true access to opportunity. Because when that happens, that's when the whole thrives. That's when we see prosperity that's really going to drive and impact health outcomes. Look, I come from a very inspirational family. And so I believe that we can get to this future state. We're just not there. My father, who I lost during this pandemic to COVID, in 2020, was a man who didn't go to college, but he was brilliant, right? He started at Bell Labs, the famous Bell Labs in New Jersey, still in that Murray Hill. It's gone through different ownership and different names, but he started there cutting grass because that was the job that he could get. It took him 6 months, which was heroic by all people's measures and standards, but he got inside of the lab. And once he got inside of the lab, it was because others shared opportunity with him. Others said, hey, we're going to put you through classes here at the lab. Hey, we're going to give you opportunities to be on this research project. Hey, your name is going to go on this patent. He didn't get every opportunity he should have gotten, but he did get some. And I'm giving folks that example is because when we are introspective like that as a society, and say, where are we blocking out opportunity and access for the whole? That's when we're truly going to be the democracy that is written of hundreds and hundreds of years ago, because we have never truly achieved that democracy. We have the life and health outcomes to substantiate that. So I hope that goes above and beyond political party or political persuasion. And we would like to see more people thrive. That's what I hope that we've learned from this pandemic. And that's what I hope we understand can make this sick democracy a healthy democracy.
Well, hearing your answer and your story with your father, I was going to ask you if you were more tired or more optimistic, but I think I got that in your answer there. Yeah. There's always the optimism, and that's what we all have to strive for. So I guess in closing, I'd say what's something that everyone who's listening, what's the thing that each of us can do to help healthcare, to help strengthen, or do something, make a difference, I guess. I'll just even say more broadly. What would you advise? Try this, do this. What's the thing someone can do?
Understand what power is. Okay? And I say that because I am on this earth without both of my parents. And I learned more about how to be more human-centered and effective physician and provider because I had to advocate for my parents. And too often, we don't have honest conversations about power. Like, do I have power? We all have some measure of power. Is this power more beneficial if I coalesce it with others who have similar conditions or have similar concerns or who come from a similar setting or context, right? I want us all to understand power, because when you can understand power, sometimes you have more power than others, and you say, what can I do? What can I do with the privilege that is afforded by my power? How can I share it? And as a physician, one way that I share power, right, because I have knowledge that is specific to my field, is by informing in plain spoken ways, informing in different formats and vehicles. Someone else who has power, you can say, well, how can I share power? That power can be sponsoring or making sure you elevate and amplify opportunity to those who do not have opportunity. You may have power because who you are, your identity is considered a norm. You're heterosexual in our world and our society. So to be able to say, how can I make a safer, a more healthy, a more inclusive circle where I have access to power for those who may not identify as myself? We each can do that brief power assessment, right? And as we do that power assessment, then we can say, how do we share that power? And finally, then how do we hold accountable systems rooted in power? I will end with this. I remember when I was at Johns Hopkins and I was going through my training in public health and preventive medicine, and I did a presentation for the rest of the residents, and it was about the quote unquote political physician. And people were thinking about through the lens of, oh, I want you to run for office. And I was like, no, I'm talking about, those political determinants of health, how you vote, when you vote, how engaged you are in the process of civic governance. Do you know who your elected officials are up and down the ballot? Because that impacts health outcomes. So those are just some tools that I think we need to have more diverse phrases, more diverse skills and expertise around the table talking about. But it begins with an understanding of power.
Well, Dr. Chris Pernell, thank you for coming on and sharing your power with all of us today. We thank you for it. Always appreciate you. Thank you for everything that you do, and just always so enlightening the conversation. So thank you so much. I appreciate you coming on.
Thanks for having me.